We have folks talking to folks in DC trying to get their mind around this and get their mind around the idea that insurance doesn't equal care, as I spoke about in my discussion. And I'm also worried that the way things are going, that it's really not very patient-centered. We talk about technology saving the day, EMRs, report cards, all these kinds of things. In the end, there's very little that I've heard discussing what does the patient think about all of this. Do they think the care is good? Do they think their health is good? It's interesting, if you actually let patients tell you that, they're usually right.
Well, basically, all very interesting points. I think what I would like to see is an increased presence of primary care within the healthcare system. I know that in Europe, primary care makes up about 50% of all physicians, and in this country, I believe it's a third. I think this is associated with lower costs because of coordinated care. So that's one thought that I have. I agree that people need choice. Not everyone wants direct care. They don't want prepaid practices. They want to determine what they want. I think systems like HSA do make me a little nervous in the sense that typically we'll pay for a bypass or some catastrophic event, but we don't tend to pay for wellness. We don't tend to pay for prevention because it's not sexy. You know, there's no Grey's Anatomy episode about primary care.
I think we have time for maybe one more question, and then I'd encourage the rest to come up to the panelists because I'd like everybody to go for a 10-minute break. So one more question, hopefully short.
Hi, also, my name is Dale Christensen. I'm a pharmacist and CEO of Northwest Pharmacy Services, which is a local, regional, I should say, pharmacy PBM owned by some 850 pharmacies in the state. I'm also a affiliate professor at the UW School of Pharmacy with a particular interest in medication therapy management, which, as you know, is part of the Medicare Part D drug benefit. My question, however, relates to the medical home model. And in my view, it works perfectly. In fact, I'm surprised it took quite so long. Within an HMO environment that's characterized by prospective payment, capitated payment, and so forth. But I haven't quite heard discussion about the question that I think is on people's minds is how well might it work under a part of a government-sponsored program. We heard that the Medicare-Medicaid comprises a huge percent of total healthcare dollars in terms of this program, but it's characterized by fee-for-service payment. And so there seems to be big hurdles in terms of paying for such things as email messages to your doctor, telephone calls, and so forth. Now, one of you, I believe it was Dr. Bliss, I'm not sure, referred in your talk, brief mention was made of the North Carolina Medicaid gatekeeper medical home model. It's characterized by a partial prospective payment, at least partial. Now, part of my career is at USC School of Pharmacy, so I know a little bit about that. But the question is, how one might go from here to there in terms of developing such a program or a model under Medicare or Medicaid without funding a medical home model, if you get the notion of it. What needs to be done?
Thank you. So just to repeat, I think the question is how do you get from where we are now to a more capitated type of model for primary care that supports the medical home, gets away from fee-for-service?
However, how could, in real simple terms, how could Medicare or Medicaid embrace a medical home model? What changes would need to be made? How would we go from here to there, to make that happen?
Great. I think this is actually underway. Just yesterday I was speaking with the Patient-Centered Primary Care Coalition, which is working on disseminating the idea of the primary care medical home and doing a lot of work in DC. And there's a lot of movement in this direction that they were talking about, that they've been very influential about. One of them is Medicare is actually talking about doing a per member per month payment, which is actually a pretty generous payment. We probably can provide all of their care for that amount. Forget about the fee-for-service billing. Anywhere from $40 to $60 a month, I think, roughly is what they're talking about. I think there are a couple of ways to get there. One is to do an intermediate step, which is per member per month payment. I think that the numbers that usually insurers and Medicare and Medicaid are talking about are too small. They're talking about a couple of dollars a month, maybe $5 a month. If you start to emphasize a larger payment per month and de-emphasize the fee-for-service billing, you get further along in that direction. I think if our country had the guts to do it, it would be great to do some pilots where Medicaid or Medicare or both pay a monthly fee for all of the care provided in the primary care medical home and set out some guidelines of what that medical home had to deliver so that you've at least got a pretty robust primary care setting and studied it and saw what the outcomes were. It's actually not that difficult to get there from here. The capitation model is already kind of understood. It's just an idea of saying, just let primary care take that payment and be responsible for primary care. Don't put them at risk for the rest of the system as they have been in the past under some HMO structures. So I'm not sure if that answers the question.
Dr. Spencer, you want to speak to that? That's a tough question.
That really is a tough question. You know, I was immediately thinking about things like malpractice insurance and all the kind of costs that people have with having a primary care practice. And I think I've been insulated within group health because I've never had to think about malpractice, some of the costs associated with being in a primary care center. And so as far as the money involved to maintain that, I'd have to actually plead ignorance.
If you think about some of the capitated payments that have been given to primary care practices in the past, I used to work in a community clinic, and Basic Health would pay between $10 and $15 a month for care, and some of that was held back till the end of the year, and you had to meet certain measures to get that money back. So, and you just really can't do it for that amount of money. But really, I mean, depending on what kind of services you offer, you could do a lot for $30 a month and still make a nice profit in your practice, pay all your employees well, and do quite well. I think this is where I'd like to see the innovation, is see practices compete for those primary care dollars, ideally directly from patients. I'd love to see whoever's going to pay for care hand that money over to the patient, maybe in a voucher form or a card or something, and say, go out there and shop for primary care. And say, and have them discipline us to compete. So I could say, well, my primary care medical home is better than yours. And you can say, well, no, mine is because we've got this. I'm going to add that extra service because I'm losing business to her. Wouldn't that be great if primary care doctors were competing and improving their services because they knew that patients were going to choose based on what they offered and that they could get up and walk away at any moment?
Right, that'd be a big motivator.
I just wanted to add something that a lot of people don't think about when it comes to malpractice insurance, is that usually patients who love their doctor will not sue their doctor. When you have established a really good relationship with your physician, you'll even forgive them mistakes. And that has been long known, and that's a little bit of, it's a little part of the I'm Sorry program. But I think it's even bigger than, and there is a program like that. But I think it's even bigger than that because there's a trust relationship and most patients will not sue. And so I think part of the reason why people sue today is because we've moved to very impersonal health care. And the patient is willing to sue this person who they can't even get to their own doctor, right? Every time they come in, there's a new doctor that they have to see. They don't really know who they are. So as we move to impersonal care, I think we increase the cost of malpractice insurance because patients are willing to sue.
I'm sorry we're not taking any more questions, but let's give them a big hand and please come on.